I am so excited about today's guest, I can barely contain myself. He's a well-known media commentator. He appeared in Fat Surgeons, World's Fattest Man, Food Hospital, and he presented The Fat Doctor for 5 series. He's always being seen regularly to comment on BBC, ITV, Channel 4, and in 2006 he set up Streamlined Surgical Clinics with Guy Slater. They have now built it up to 9 locations in the UK with 14 other bariatric surgeons. Today, it is one of the foremost centres for weight loss, both surgical and non-surgical. He is by far the nicest human being you will ever meet. Please welcome Mr. Shaw Summers. Thank you so much for being here, Shaw. I really appreciate your time. I want to start off really by talking about obesity. I know that the World Health Organization has officially declared it as a disease and that it's got a complex nature. Do you see it as a disease, and what qualifies it to be a disease, and what's so complex about it?
So the prevailing wisdom really until about 5 years ago was that this is a self-inflicted condition. In other words, you've eaten it and you've put the weight on despite the control which you should have had to stop it. And we've learnt, certainly over the last 15 years or so, that your human metabolism is really complicated and that we're not all the same. There are some people who have a fast metabolism. In other words, they burn off calories really inefficiently as it happens. You know, they burn energy when they don't need to. And there are others who hang on to the calories. And that's because we are all individuals. There are no two humans that are absolutely identical. Even identical twins have differences. The genetics may be the same, but the way those genes are expressed, as we now say it, are different. So that's a very long-winded way of saying that we understand that the way your body deals with food, how it digests it, how it assimilates it, how it sucks all the goodness out of your food, and how it spends that energy and that food is different for every individual. And it's regulated by a very clever set of regulatory processes, which we just don't understand completely. And those regulatory processes can break, just like the process that regulates your blood pressure, for instance, can break and you get high blood pressure. It's nothing you've done wrong particularly, but you get high blood pressure and you go to the doctors and you say, I've got high blood pressure. And they go, take some tablets. It's a disease, it's a disorder. And we now recognize that due to genetics, our environment, and we can go on to that a bit later because it's a big subject, the human environment, our food, our work lives, our stresses, pollution, whatever, our genetics, our environment, and the foods that we have available to eat have all contributed to what we call an obesogenic environment. And there are some people for whom that translates into weight gain and a disorder in their metabolism. And once that metabolism gets disordered and you go past a certain point, you can't wish it away. You can't think it away. You can't diet it away. And that is why the WHO have now recognized obesity as an illness, a disorder. And it's why drug companies are spending millions trying to figure out drugs that help treat it, and why bariatric surgery has become a mainstream treatment for those in whom the disorder is really quite severe.
Oh, thank you. Yeah, because I think recognizing it as an illness is going to help so many people, because I think so many people with obesity, me included, blame themselves. why can't I lose the weight? Why can't I stop eating? And interestingly, environment is a play, like you say, plays a very, very big part in that. Let's expand on that a little bit. I mean, I was aware when I think of environment, I think of even the people that I'm with, whether it be parents, family, friends, loved ones. If they're not obese and they go out, they enjoy themselves, they have as much food as they want, and you are mixing in that environment, it's kind of destructive to what you would need to do anyway. But environment is a lot bigger than that, isn't it? Like you were saying.
It is, yeah. It's tied in with the whole of human behavior, really, right down to not just hunger and the foods and what you're presented with to eat, but also how you sleep, for instance. And we now recognize that good quality sleep is absolutely essential to be able to moderate your metabolism and for your body to work properly. So people who stay online until 2 a.m, either playing games or doom scrolling, that does things to your brain and your stress center so that you are constantly stressed. And that stress leads you to having higher cortisol levels, endogenous steroid levels, which make you more hungry and slow down your metabolism. So even things like that people wouldn't normally associate with weight gain and struggling with weight maintenance has an influence. So the environment is the way you live your life, the stresses you're under, the foods you find available to eat, the choices you make with the foods. And all of those are driven by how your brain is working. And, it varies individual to individual, circumstance to circumstance. And also, I have to point the finger really at the food industry and say, well, you guys have a role in all of this, but currently your role is such that you want to make the most profits possible. And you do that by substituting good quality natural ingredients for the cheapest stuff you can possibly chuck in your foods to make more money. And that kind of thing is just not helpful for the body.
Plus the chemicals they put in them. My cousin was staying with me this weekend and she bought one of these high protein breakfast shakes. And I said, Max, I'm happy to make you breakfast. No, this is fine. It tastes really nice. I said, what's in it? She goes, well, I don't know. I said, well, have a look at the label on the back. And she struggled to read it. And I said, honey, the reason you're struggling to read it is because you don't know what those things are. They're not natural food products. What are they doing to your system? And I think it's really important that people think about that.
It is important because, I often use the analogy, if you look at wild animals in their own environment, so you look at a herd of zebra or antelope, all the adults are the same size. There's no fat ones and thin ones. And they're out there on the grasslands eating grass, which is what they're supposed to eat. It's what they're designed to eat. And humans were like that at one stage when we were just basic hunter-gatherers. I can't imagine there were very many big ones, but there was food everywhere, and you knew what was good and what was not good and what was in season and what was not in season because we had a nose and a taste, and these things were almost like natural. No one teaches antelopes to eat that kind of grass but not that kind of grass. They just know. And we used to be like that. Humans were like that. But over certainly the last 1,000 years, but mainly the last 100, 150 years, where industrial urban food supply has really been the main source of human nutrition, we've just binned all of that knowledge and we don't cook from scratch and fresh anymore, not without paying a lot of money and having the time to cook from scratch, which people just don't have these days. So we've invented a food environment that just is at odds with how our bodies work. Our bodies can't register high fructose corn syrup. It just doesn't know how to regulate it. Whereas if I was to give you a slab of butter, a dairy product, your body's much more adept at going, that's enough. You don't want to eat any more of that. But high fructose corn syrup, you can just keep popping in as long as you like, and your body will keep going, yeah. And that's unfortunately, the food companies know that that's how they make their money. It's by the yum factor and the fact that high fructose corn syrup costs nothing to make. It's cheap, really cheap.
Yeah, and actually, you made a good point, especially about animals in nature. If we look at our domestic pets nowadays,
Yeah.
they are fed shop-bought food. And I know when I take my dog for a walk, he will pick up anything off the ground. He's lost his ability to know, well, what I should eat and what I shouldn't eat.
Yeah.
He's lost
And
his
also,
ability to know if it's even healthy or good or gone off.
well, it's also the appetite thing, because we now know that your appetite and your satiety. So satiety is when you've eaten enough and you feel satisfied. So you look at a big plate of food and you go, do you know what? I've eaten enough. I feel full. I feel happy. I don't need to eat anymore. And those two things are regulated differently. So feeling hungry, yeah, everyone knows if you go without eating for a bit, you go, I really want to eat something. But the satiety thing is also quite important. And if you eat certain foods, you switch on satiety a lot more quickly. So what kind of foods? Proteins and fats switch on satiety. Carbs, less so. Sugar, very little. High fructose corn syrup, not at all. But the satiety thing is really important, because if you look at wild animals in their natural environment, they'll eat grass until they feel nicely full, or their body says, right, that's enough. You've eaten enough for today to keep in calorie balance. Stop. And they go off and do something else, play with the kids, whatever. Unfortunately, when your metabolism breaks down and you develop the disorder of obesity, that satiety thing isn't there. It just doesn't switch on. So you can eat, and people often tell me when I talk to them about their struggles, why it is they feel that they can't control their weight. It's just like, I have no off switch. I'll keep eating till I literally can't breathe. And I then think, what have I done? Why have I eaten this much? And it's because your satiety mechanism is non-existent. It doesn't switch on like it should do. So you have a disorder, a metabolic disorder. And that's why we've started to change the name from bariatric surgery, which makes it sound like, we're treating you special because you're obese, to actually metabolic surgery, because we're treating your metabolism, and that's exactly what it does.
Oh, I didn't know that. That's good to know. There you go, everybody. We've learned that today. Bariatric surgery is now going to be called metabolic surgery.
It is
And
metabolic surgery.
it sounds kinder as well, doesn't it? Bariatric's quite a harsh word.
Well, it does, and it implies you've got to be the size of a truck to need it. And actually, we don't. We treat people who are not very overweight, but their metabolism is badly awry. So you can be very overweight, but actually your liver function is good, your blood pressure is in line, you're not diabetic, and all you are is just very heavy. So that's what we call the fit obese people. And quite rightly, if they want to lose a lot of weight, we have treatments that we can give them. But we have people who are just a bit overweight, a couple of stones or 15 kilos overweight, but their metabolism is shot. They've got fatty liver, they're diabetic, they've got high cholesterol, and they've got blood pressure. And for those people, metabolic surgery, what used to be called bariatric surgery, is probably the right treatment, because they need strong treatment to treat their metabolic disorder, which is caused by excess consumption of the wrong kinds of foods. And the surgery is one way of helping switch back on the metabolism as it should be working, switch back on satiety so that they can stop eating the sweet stuff and the things that don't help, and give them a chance of a better quality of health, better quality of life.
And just to clarify, then, we're not talking, I mean, this is not a green light for anybody who's a couple of stone overweight to ring a weight loss surgery clinic and say, right, I want weight loss surgery. These are a specific group of people who may not be 10, 15 stone overweight, but health-wise, they have a lot of other conditions that would suggest you need some help to reset your metabolic system.
That's correct. And unfortunately, there's plenty of them out there because, metabolic disorders, as we now understand them, are actually very common. It's the commonest cause of the things that then lead to an early death. So medicine's very good at putting things into silos. If you've got a heart problem, you go to a cardiologist. If you've got diabetes, you go to a diabetologist. If you've got cholesterol, you go to a lipid specialist. We now understand that all these conditions are linked together as a metabolic disorder, and it's the primary problem is that your metabolism stops working correctly, usually as a result of putting on a bit of weight, not necessarily a lot, but a bit of weight. A couple of stones will do it. Your metabolism stops working correctly, and that accelerates ischemic heart disease, high cholesterol, fatty liver, all those things that put you at a high risk of having a heart attack or a stroke or an early death. And it's metabolic syndrome, as we now call it. But that cuts across all these specialties. And the difficulty we've had as doctors is tying all these specialists together and going, you're all treating the same thing, guys. It's all metabolic syndrome. But you're seeing the heart side of it and you're seeing the diabetes side of it, but it's the same thing because all your patients are a bit overweight or a lot overweight.
But you said something just now that was really, really interesting. And it's a shame that really they don't teach this in detail in schools. Because what you said was that your metabolic system can break down because you've put on a bit of weight. People don't realize that putting on weight doesn't just make your clothes tight. It actually has an effect on how your body works. And I think if people knew that and they knew it early on in life, they could possibly take steps to make sure that they try not to put on weight going forward so that they can keep their body in the ultimate performance level required for good health.
Yeah, absolutely. And I think preventive measures are always better than treating it once it's happened, because we measure the occurrence of obesity on the scales, but by the time you put on 2 stones and your shirts are tight, there's a lot of other things that are tight inside your body that really don't function well if they are tight. But I think in terms of prevention, it is actually pretty simple. You've just got to avoid ultra-processed foods and sugar. Now, it's not an absolute, but just cut it right back. So we have in nutrition a number of things that your body has to have in order to stay alive and function. We have essential amino acids, which come with your proteins, without which you're going to die. We have essential fatty acids, which come with all the fats that you consume during the day. And bear in mind, our bodies are made of a lot of fat. Every cell has cholesterol and fats in its membrane. So you cannot live without fats. This fat-free idea is a complete myth. So you need fats. So quite often after surgery, people say, oh, I'm on a low-fat diet. I'm going, no. Eat your fats. You need them to take in your essential fatty acids and your fat-soluble vitamins, without which you're going to die. When it comes to carbohydrates, the other triad of what we eat, there is no daily requirement for carbohydrates. None at all. You can make your own glucose to feed your brain in periods of when it needs it, from your proteins and from your fats. You've got the machinery to make carbs. So you don't need any carbohydrate intake. It's nice to have it, and there is a balance so that when you intake carbohydrates, your body will digest them and use them. But certainly not as a third of your calorie intake as carbs. That was invented during the era of agricultural expansion back in the day, around 2000 to 5,000 years ago, when humans suddenly learned that they could grow this stuff and turn it into bread and other staple foods that gave them energy, that powered them to go and work for money. And that's when it all grew up, and it was just a way of powering the most efficient machine that we know. Even in modern days times, the most efficient machine is the human muscle. It's amazingly efficient. It needs tiny amounts of energy, and it does amazing things. It's really very strong.
Yeah, I really hope that the listeners hear what you're saying and take something away from that, because unfortunately, we live in a world where everything is about convenience. So the processed foods are the easiest thing to grab hold of, the pre-packed foods. And even in terms of, the carbohydrates, it's so much easier to come home and bung some pasta on the boil and smother it in cheese, and there's your dinner for the night, rather than grilling a piece of chicken, which you could do just as quickly with some pre-prepared salad or some veg that takes no time to cook. And
I know, but it's I think there's two things here. It's about knowledge and the education of how you create the time and how important that time is to cook, and also the confidence. People think that it's got to look like MasterChef, otherwise they're a failure. And it's just like, no, that's not real. That's not real life. It's all, but that food's been sort of pimped to within an inch of its life.
I'm not going to invite you round to dinner at my house, sure, because honestly, yes, I cook from scratch, but by the time it ends up on the plate,
I know, but as long as it tastes nice and it's good quality, who cares what it looks like, really? But I have to say, for those who cook for themselves, I think you've got to understand and develop a sense of satisfaction that you can do that, and you've done that. And it is good meditation time. It's good downtime from looking at a screen or doing more work or things that aren't going to give you that little sense of relaxation and rest. And for me, having rediscovered helping my wife cook and being sous chef to Mrs. S, it's actually our bonding time. We spend time together prepping stuff in the kitchen, cooking it, having a laugh, watching me drop stuff, cut the end off my finger, that kind of thing. And that's the social time that we've lost in society, because everything has to be convenient and it has to be ping food. You buy it in a box, stick it in the machine that goes ping, and then you eat it and you go, yeah, it was all right.
Please tell me that the top surgeon in the UK doesn't cut his fingers off when he's preparing food.
I've still got them all, thank you.
Oh, it's brilliant. But sure, you've had such a varied career. Going back from when you graduated university, which you said happened by accident, really.
Yeah, it did.
Yeah. You've travelled a lot. You've worked in many different places. You've worked in cancer units. So what was it that made you the switch to bariatrics? I'll call it bariatrics for now.
Yeah. So why did I decide? Because I'll tell you the interesting story about that. So back when I was training, weight loss surgery, bariatric surgery did not exist as a specialty. It was like people had heard about it in the 70s and 80s. There were a couple of guys in America doing it, and everyone thought, why are they doing that? There's more important things to treat, like cancer. So I was trained as a cancer specialist, so I could take out people's stomachs and gullets and things like that and make it all work as a way of treating cancer. And it just so happened that the operations that people were doing to help people lose weight are very similar to cancer operations, except we don't take bits out, we just shift them around a bit and everything still works. And so for me, it was a professional interest of, that's interesting. You can do the same sort of operation as a cancer operation, but things work, you can still eat, and people lose weight, and their metabolism gets better, and their diabetes goes away, and they feel great. And it's like, so how does this work? And, around the time I was finishing my training, so we're talking, mid-90s, a long time ago now, bariatric surgery really started to gain traction as the obesity epidemic started to do its meteoric takeoff. It was becoming clear that in the States, people were having to train to do this operation or these operations and treatments because it was really needed. And this was going to come to the UK. And I was very lucky to work with a chap called Stephen Pollard, who's one of the great-grandfathers of British bariatric surgery, who went over there to learn and came back, and I was lucky to work for him, and he taught me the ropes. In the old days, it was through a little cut in the tummy because keyhole surgery was just about coming through. But I was one of the first to actually start doing this stuff keyhole. So instead of making a cut in the tummy, you could put little keyholes inside and do exactly the same operation, but with much quicker recovery, much more safely. And people would come in and a day later go home going, I'm not hungry anymore. I've just looked at my favourite foods and I don't want to eat them. I'm a bit peckish, I'll have a little bit, but I don't fancy eating it all. And they go, this is amazing. As you probably found yourself.
I did. I remember actually when I was recovering after I got home, I was over at my mum and dad, and my brother came in, and I was still on soft food. Obviously, I was eating a yogurt, and I was struggling to eat. Not struggling, but it was taking me ages, and I couldn't finish a small pot of yogurt. And my brother looked me straight in the eye, goes, "At last, something that's going to work for you." But absolutely, you just don't feel hungry. Yeah.
So you don't feel hungry, and even if you do, a few spoonfuls, and it's like, I've had enough. Don't fancy anymore.
Absolutely.
And it's not uncomfortable. It's not. See, a lot of people who could do with help, a surgery especially, are frightened because they think, I'm never going to enjoy food again, and that's not true. You enjoy food, but you just don't need to finish it.
Yeah, and you learn to enjoy different food. I mean, I know that I have completely changed, or organically changed. I didn't even set out to do it initially, but my tastes have changed, and I no longer see food as a treat or something to get necessarily excited by, because I now see it as a necessity. I need to eat, and therefore I can make better choices. But so as part of what you do at Streamline Surgical, you offer different types of surgery to people. What are those different types? What are the differences between them as well?
So we've undergone in the last sort of 5 years, especially with the advent of the new injectable drugs, which are great, they really work well. But we now view obesity as a spectrum of diseases. So if I can use the analogy of blood pressure again, if someone says to you, I've got high blood pressure, it could mean a little bit up, or it could mean sky high blood pressure. It's a spectrum of severity. And it's the same with obesity and metabolic derangement or metabolic disorders. You can have a bit of it, or it can be really bad. Now, obviously with obesity, someone who's very, very overweight has a severe form of the problem that is going to need a strong treatment. Someone who's a little bit overweight, or they're a little bit overweight with metabolic syndrome, the fatty liver, the diabetes, they might need a strong treatment too, because actually we've got to reverse the high cholesterol and the blood pressure. Otherwise, they're going to have a heart attack. So you don't want to be messing around with a weak treatment. You want something that's going to do the job. And so we now see all the different treatments that we have available as a spectrum. And that's why it's really important, fundamentally important, for people who are considering having treatment for obesity or metabolic syndrome to speak to someone to give them advice, because you can't figure it all out for yourself just looking on the internet. That's why streamline weight loss, as we now call it, because we do the injections, we do the non-invasive treatments, and we do the invasive treatments like surgery. We have a whole sort of spectrum of treatments we can use for people who might not need one or the other, but they just need a bit of direction. So if you went to the chemist or bought a blood pressure monitor and you saw your blood pressure was sky high, would you go on the internet, look at the different sorts of tablets for blood pressure and go, I'll try that one and give it a go yourself? You wouldn't, would you? You'd go, no, I'll go and see the doctor, and the doctor can tell me what tablets he thinks are going to be best. When it comes to obesity, they don't do that. They go online, they go, oh, I'll have some of that M word or the W word, and they'll go buy the injection. They fill out the form, go buy the injection, which there are many pharmacies out there who will just sell you whatever you like without asking you a single person-to-person question by a doctor talking to you about exactly what it is it you need, what are your liver tests like, what is your blood pressure, all this kind of stuff that informs what kind of options are likely to work. Yes, the injections will get your weight down a bit, but is it going to bounce straight back the second you stop them? In which case you might as well have had a stronger, proper treatment and saved yourself a lot of money by having a very simple, straightforward operation.
I do want to talk to you about the weight loss injections, actually, but before we do, just very quickly, so before we come on to the GLP-1s, the different surgeries that certainly that you would perform. I know that 21 years ago, in 2004, I had a band fitted, not by you. I had to go up to Birmingham, had problems with it, and you thankfully took out the band and converted it to a Roux-en-Y bypass. And I know you still do the bypass. What else do you do? Because am I right in saying the bands are not as common as they used to be?
Not as common. They're a good operation for the right people. So principally, I would do a band in the very young, because they need something that is not going to damage particularly their stomach, their gullet, their digestive system. We're not cutting their stomach away at all. We're just going to restrict how much they can eat, because in likelihood, if someone aged anywhere between, say, 14, 15 and 25, if they're already struggling seriously with their weight, it's likely they're going to need treatment lifelong. So let's start with something simple and reversible like a band, and then we can move up the treatment scale later on if they still need it, which is very likely. So we do still do bands, but less frequently than we used to, because there are probably better alternatives that work much better. And the operations that are in common use now are the sleeve gastrectomy, which is pretty simple on paper, but in my view, to do it properly, it's one of the most complex operations to do properly in a way that it's going to last. But everyone thinks it isn't. It's a simple op. Oh, I'll have a sleeve. If you have a badly done sleeve, it's a disaster for the individual. Your life is never going to be the same, and you're going to have it changed to a bypass. So you're going to have two operations now, not the one that you thought you needed. Again, this is about having a consult with someone who knows what they're doing, who does this for a living in the NHS as well as privately, because it's my specialty. So you want to go to a proper bona fide bariatric surgeon, have it done properly, not some bloke in Turkey who you've never heard of, or some bloke in the UK, although it's rare in the UK now to get non-bariatric surgeons having a go. But in the past, it was, Wild West. So we do the sleeves, we do the bypasses, and there's two sorts of bypass now. What we call a loop bypass used to be called the mini bypass, but there's nothing mini about it. It's a bypass. And the Roux-en-Y bypass. And I tell people, please don't get hung up about which sort of bypass you want, because it's not a decision that you are, unless you do a medical degree and train as a surgeon, it's not a decision you're going to be able to weigh up the pros and cons of. It's a decision that is really down to what the surgeon feels is going to work best for you, so that you get on with your life without thinking, oh my God, I can feel a bypass in there. Because you can't. You get on with life, you feel normal, other than you can't eat that much and you're not that hungry. So we do the sleeve, the bypass. There are a number of other operations that are being trialed and tested. The bigger ones, things like a duodenal switch, the malabsorption operations, we tend not to do, because long term there are big problems with those in terms of developing osteoporosis and other sorts of metabolic disorders, because you've bypassed most of the gut. And if I'm honest, whilst the weight loss is great in those operations, the longer term side effects of those operations are not great. And I think most people who've had those big operations, the malabsorption operations, when they're sort of 15, 20 years into them, are going, I'm not sure I'm enjoying this anymore.
And yeah, see, that's really scary, isn't it? But also, does that mean that each different operation will produce different results in terms of weight loss?
Yeah.
Okay.
Yeah, they do. So in our hierarchy of treatments, we start off with the weight loss tablets like Orlistat. Doesn't work very well, but it's very simple and safe. Then you've got things like the GLP-1 injections. They work pretty well, actually. Not as good as the operations, but they work pretty well, and they're pretty safe. You might get gallstones, you might get a number of other relatively minor side effects. Then we come on to the operations. We had the gastric band, it works a bit better than the injections. Not a lot, but a bit better than the injections. Needs a bit of maintenance, but it's reversible. Then we come on to the sleeve, which is a bit better than a band, but not as good as a bypass. But once you've had it, you've had it. It's a one-way trip. Once they've done the sleeve, there's no going back. Then there's the bypasses, which are probably the best, most reliable operations that we have. They will definitely get your weight off. They will definitely work for at least 10 years before you have to start thinking about how you eat, what you eat, lifestyle, etc. So the op will work automatically to start with, but then after that, if you don't change your lifestyle or you slip backwards in your lifestyle, you will then start to put a little bit of weight back on.
Yeah, that's exactly why. Yeah, that's exactly.
We can talk about keeping it off.
Well, absolutely. I mean, to be honest, that is why it exists, because, I'm 21 years post-op. I went through a phase where I started to regain. I thought, no way have I come this far. I need to work out what's going on here. So you're right. I mean, and I think that's the issue for a lot of people, is that they don't realise that they have to change their lifestyle and their mindset for any procedure to work long term.
Even the injections, people who take the injections, they're like magic. The first 3 to 6 months, it's like, oh my God, I haven't had to do anything. And all of a sudden, I'm losing weight. And that's because the injections have switched on the metabolism, turned on a bit of satiety, and made you a bit less hungry. They've done all the magic things that an operation would do. But like an operation, there is a period of honeymoon where it's working like magic. And then your body starts to tolerate and then not exactly fight, but reverse the changes. So with the injections, people have to take stronger and stronger injections as time goes on, and they find themselves on the top dose and going, I'm feeling hungry again. And that's it. There is nowhere else to go. And as soon as you stop the injections, boy, do you get hungry. Whereas with an operation, it works like magic for 2, 3 years, 4 years, and then you have to behave. Otherwise, you will put a little bit of weight back on, because the procedure fatigues with time, things stretch a bit inside, but also the hormone changes that regulate your metabolism and your hunger and satiety start to reverse back or revert back towards where they were. They never go back completely. So anyone who's had an operation rarely goes back to their pre-operative weight, really rare. They might put a bit of weight back on, which is distressing, but they rarely go back to where they were. Whereas I've seen plenty of people who've been on injections, GLP-1s, and they've stopped them, and all the weight goes back on, and then they come and see us at Streamline and say, what next? What can I do? Well, you can just do repeated courses of injections. There's nothing wrong with that. But actually, if you want a solution that is going to be robust and to last, we need to talk about an operation.
And that brings us nicely on to the GLP-1s. Have they affected the surgical industry in a negative way at all, or are they now starting to come hand in hand together?
So initially, yes, it was like a catastrophic decline in the amount of surgery that we were doing. Certainly privately, on the NHS, you can't get the injections, so people still come forward for surgery. And we're very good at sort of saying to people, actually, you shouldn't have surgery. You should try the injections. And I don't have a problem with that. It's about the individual. It's about what the person wants, what they need, not what I want to do to them. So strangle. So I think, yes, it did affect us, and we did see quite a decline in surgery, but it's coming back now, as some people who were hopeful that the injections would do the job for them realize it's not the way forward. And actually, if they really want to sort this out for the long term, they need to talk to someone like ourselves and actually have a proper medical discussion about, how do I put this right? How do I get a grip of my health and my quality of life? Because for me, I can talk about, improvements in health and measure health outcomes and all this kind of stuff. The majority of people who have surgery with Streamline say the most dramatic change has been quality of life, confidence, enjoyment of the little things, all the things you give up because you don't want to do it because you either feel too heavy, uncomfortable, or embarrassed to do them. All that goes away. You become normal again. You start enjoying the things that everyone else enjoys because you are like everyone else. You're not big anymore.
I can absolutely second that. I'm testament to that. I remember right in the early days when I lost all my weight, I thought, oh my goodness, I looked in the mirror and there she was. That was the person that I had always known was in there. And it was like I was meeting her for the first time. And my life bears no resemblance today to what it did in 2007. None whatsoever. So I agree with you.
I think that's a really important thing to press home to people who are considering any form of significant weight loss treatment, even with the injections, that your life changes as your quality of life improves and your ability to do whatever you like, because you can. As that changes, your life changes, and that can be a real strain on relationships, on work, on things that you took for granted that actually you don't want to take for granted anymore. You don't want to do those things anymore. People will see you differently. People who used to be, enjoy being with you when you were the bigger, funny one who kept everyone happy, and all of a sudden you're not big anymore and you want to do your own things. You might find there's friends who are jealous that you've lost the weight and they haven't. All these things are part of the transition from being obese and overweight and struggling with life to being normal again.
Da da da! Don't hate me, guys, but Shaw and I were talking for so long that I just can't fit it all into one episode. So he's coming back next week, and you are in for even more of a treat, because next week he is going to do a really, really big deep dive into the GLP-1s. You are not going to want to miss it. Whatever you've been asking yourself, whatever you want to know, he covers it. We'll see you next week.